Marianne, could you just introduce yourself first, I suppose, to the audience?
My name is Marianne Jauncey. I'm a doctor, I'm a public health physician, and I'm also the medical director of Australia's only supervised injecting facility in Sydney.
Mm-hmm. And that's in King's Cross?
Yes, in King's Cross, which is very well known as an area where there's, for many, many decades, been the sale, purchase and use of illegal drugs.
Mm-hmm. Yeah. Obviously, it's also filtered up to Queensland, where I'm from, so yes, we know about that place. So probably what we're trying to do here today is just have a look at, because the centre's been going on for a number of years, and it transferred from a trial, and there was a lot of evidence base built around it and science and everything like that, but then it's gone to a permanent basis. So what got it through that way, through there?
So as anybody would know that's had any even cursory sort of look at the history of our centre and really most supervised injecting facilities, they're obviously very politicised, sensitive services when they first opened, and ours was absolutely no exception. We opened in May of 2001, and we were the first in the English-speaking world. And we opened at a time when there was a real focus, especially on drug-related death, and a lot of public conversation and public concern about drugs per se. The government didn't run it. They said that they wouldn't stop an independent organisation putting forward a proposal to run a supervised injecting facility so long as the local community were supportive, which in King's Cross, in fact, they have always been supportive. Indeed, that support has increased over time as they've seen the benefits for the service. But the government, understandably, was very cautious, and so it was announced as a trial or as a pilot. I think at that stage there was a hopeful sense of, if the evidence shows good results and it will be independently evaluated, then we'll act on that when it comes. But I think probably a cautionary tale for all of us involved in public health and in politicised services is the evidence alone is never enough. It's necessary to have it, but on its own it is never, ever, ever enough. And the more I study public health and epidemiology, the more I realise it's personal stories, it's education, it's advocacy, it's changing the public conversation, it's speaking to people one-on-one, it's finding your community leaders that are supporters and are going to lead on this and standing up and being counted, and finding the political support as well. Okay.
So what was the hardest bit, do you think, of that, of all of those things that you're getting done?
Depends. I mean, it was hard to get it open in the first place, and certainly there was a number of years of, it was first recommended formally to New South Wales government as a result of a royal commission into police corruption in New South Wales, and there was a very clear explanation that was given at that point when Justice James Wood, who is the author of the final report, very appropriately said, we give clean injecting equipment to injecting drug users on the full understanding of what they're using the equipment for. So we've already been doing that for many, many years. To thus shrink from providing a safer and more sanitary premises is somewhat short-sighted, was how he put it. And I've always thought that's a very good explanation. We need to remember that there's good support and good understanding and extremely good evidence as to why we provide clean injecting equipment, and certainly in my country, in Australia, there's very good public support behind it. So I would argue the leap is not putting a roof over the heads of the people using and putting walls around that activity. It's good for the local community, it takes injecting off the streets, and it's obviously good for the individuals involved.
Okay, so like with the geography, I suppose, of the Cross and the geography of city, which is quite a large city, I suppose.
Very spread out.
You've experienced Glasgow a bit, you've had a bit of a wander around some of the places, looked around the naloxone facilities, etc. What do you think, how would that work with the way the geography is here?
So I think all supervised injecting facilities that I've visited around the world work by being located really where the sale, purchase and use of drugs is occurring. If you open up a supervised injecting facility or a drug consumption room that also may have inhalation facilities, if you open it up in a place where there's no drug users, it's going to be an enormous waste of time, effort and energy. So you really need to open them where there is somewhat of an open drug scene. The other thing I think that I've learnt though is, certainly our service is a large standalone facility, and to have a public impact at a population level we needed to be quite a large facility, and there was an enormous need. we had the highest rate of overdose deaths in the country, in the King's Cross area. And within 200 metres of where our front door is now located, in 1999 we had more than 650 ambulances being called to accidental heroin overdose. So there was a really concentrated epidemic that was going on. So it was appropriate to respond with a large sort of standalone facility. But I also think increasingly it is appropriate in certain settings to look at multiple smaller services potentially being open, depending on what the local scene is. And I think it's crucial to remember that a drug consumption room is really very much a local solution to a local problem. So I can talk about what worked really well in the Australian context, but you know, if and when one opens in Scotland, it really much needs to be very much a response to the local, you know, scene of what's going on in Glasgow.
Has there been any talk of more facilities opening across Sydney?
So what happened with us is that we operated as a trial status for nearly a decade, which I have to say, as far as I'm aware, would have to be the longest running medical trial, you know, in the medical literature. And that was because of politics. And so in the dying days of the then Labor government, on the brink of electoral annihilation, they wanted to tidy up some loose ends and make us a permanent service while they could. But for political reasons, they chose to put into the legislation that there will only be one such facility in the state.
Oh, right, okay.
Now, you can understand from a political point of view why they did that, so that other MPs hanging on by a knife edge to keep their seat weren't inundated with calls of, oh, when's there going to be an injecting facility in my backyard? But of course what it's meant now, where there are other facilities that are interested and where there is support for it, is very difficult because we need government action. And mostly, I don't know about here, but mostly for us, politicians would rather not get involved in this stuff. It's fine that there's evidence and they're not necessarily trying to close us down, but they don't want to make news by having to pass something through Parliament to allow another one to open. So if Scotland's going to do anything, don't put something in your legislation which dictates when and where and how. Allow it to be determined on a needs basis as any other health facility should be.
Well, it's a Murdoch-controlled press there as well as here, so you know we have much similar difficulties within our public persona of those things. Okay, so I'll just need to put on my glasses so I can read a bit. With the security, we're looking at, because what we've discussed here in Scotland is with heroin-assisted treatment as well. So we were looking at, what are your thoughts about the co-location of clinics? Because you know, you're putting the injection facility in an area of high need. If we're looking at heroin-assisted treatment, there's likely to be a strong crossover amongst that population. So we're looking at, is that an option to co-locate? But what kind of implications come from that? What would your thoughts be? I know it's not happened in Australia with the heroin-assisted treatment.
Well, we don't have any heroin-assisted treatment.
And
the heroin-assisted treatment that I've visited in Switzerland is certainly in a different location to their supervised facilities or drug consumption rooms. So that I'm aware of, there's no heroin-assisted treatment co-located within Europe with another drug consumption room.
Do you have methadone co-located? No? No. How close is the nearest?
Probably 2-3 minute walk from where we are. So in terms of co-location of services, I think it's really crucial to have other wraparound services either available on site or very, very, very close by and integrated in with the running of the supervised injecting facility for a number of reasons. One, from a purely practical point of view, making contact, developing a therapeutic relationship, gaining that trust of somebody, which you know, a supervised injecting facility does extremely well, to translate that into practical action and get them to see a caseworker, see a nurse, see a doctor, see a social worker, you know, talk to somebody about housing, all of those things. It needs to be pretty much a one-stop shop. You know, reduce the threshold, reduce the barriers, make it easier for someone so that they're not having to traipse all over town and get public transport, whatever.
I've got to go there.
Yeah, it's not going to happen. If you want something to happen and it's important, make it happen and co-locate them. So in terms of those wraparound services, I actually think that's a very good idea. We had good facilities in King's Cross, so there was a sense that we didn't want to duplicate services. But in the end, and because it was only a trial and there was always concern that it may close without government support, and then if there's too many facilities, we might lose them.
Yeah.
So I think there was good practical reasons why we made it sort of a standalone facility. But then in retrospect, we've been sort of bringing in the other services and doing outreach with them on site. So I think generally speaking, co-location of services is an extremely good idea and we should do far more of it. Too much of health is divided up so that it's convenient for us as the clinicians. We need to divide it up so that it's beneficial for the patients that we see. Look, I've got mixed views and it'll be interesting to have more discussions with other people. I've certainly worked at a very good one-stop shop service in King's Cross before the injecting facility opened, where we had needle syringe programs, what you guys call IEPs, as well as doctors, as well as nurses, as well as social workers, as well as methadone, all within the one area, and it worked extremely well. Often there's a sense that you can't provide clean injecting equipment at the same place that you're providing drug treatment because that's too much of a temptation. To be honest, I think the reason that we're putting people on methadone and buprenorphine is because they have been injecting drugs. So to somehow pretend that that's not a part of their everyday existence, to me, I'd say that seems somewhat short-sighted. And it's not as if probably they're not being faced with other temptations. So I think it encourages a much more open dialogue with the treating doctor and the treating team, the multidisciplinary team, and acknowledging, like I always used to say to my methadone patients, look, you know, we're starting you, but it's not going to hold you for at least the first week. So, you know, when you're using, if that's what you're going to do, I'd talk to them about using less and, you know, waiting until the methadone had, you know, onset of action had started. So it is about acknowledging the reality of people's lives, and I think for too long we pretend that we can't talk about ongoing injecting if somebody's on
someone's
on
going to be
treatment.
totally clean, and someone will come into a needle exchange facility and they'll be and obviously if they've been using methadone, and then over here they won't disclose.
Yeah, because they're frightened of getting their takeaways removed, and I just think in other areas of medicine, the whole point is to try and have an open, respectful, non-judgmental relationship with your patient or with your client. Well, why the hell is it any different in drug and alcohol? Surely it's actually even more important in that area to have an open, respectful, non-judgmental conversation with your client from both sides of things. Yeah. So I can see that there's benefits in terms of, you know, and also from the public's point of view, I think, you know, the big myth is that supervised injecting facilities don't provide the drugs. We run public tours all the time and I'm constantly being asked by people, so where do the drugs come from? And I'm saying supervised injecting facilities allow an activity to occur that would otherwise occur in public or an unsafe place. And they're saying, but don't you provide the drugs? So I'm constantly getting asked, oh, hang on, don't you provide the drugs? So I think there's often a public perception that we do provide, you know, cleaner, safer drugs for people to inject. So I don't think necessarily you'd have a pushback necessarily from the local community. My sense is it would be very helpful to have close by, whether or not within physically the same space or you know, I'd be interested to get other people's views.
Okay. We'll have more that discussion tomorrow, I suppose. And just as a last final thing, what are your thoughts about the way that HCV treatment has changed? It seems the whole landscape's changed in Australia, the way with a large-scale push on funding so that treatment is available.
Go Australia. It is fantastic what is happening in Australia at the moment. We've got a federal health minister which has provided free hepatitis C curative new regimen treatment available to everybody, regardless of whether or not you're injecting, regardless of what your genotype is, regardless of what your FibroScan score is or degree of liver damage is. And it's an absolute game changer. So where I'm working, we're working very proactively with some of the other local services and really trying to look at treating small communities of people so that we can basically reduce transmission. And it's generally an absolute game changer. We could look at eradicating hepatitis C if we do this well. Cool. So very exciting. Very exciting.
Aussie, Aussie, Aussie.
Oi, oi, oi.
Yeah. Okay, thank you very much.
The one other thing I would say, if I had to say what are the factors that got the supervised injecting facility over the line in terms of public opinion in Australia, to me there was really three things that were crucial. The first was that we had the police support and we had explicit support. and cooperation from the police, so that we have a licence that's granted to my mothership, which is an organisation called Uniting, which is an NGO. But it's the head of health and the head of police in the state of New South Wales that actually grant that licence. So we're intimately involved with the police, and the local area commander and I have a very good relationship. He'll call me if there's problems, I'll call him if there's problems, and I think that's crucial, both from a practicalities of how the centre runs, but also from the point of view of public perceptions. If the police are supporting it, it sounds a lot more. The fact that we ultimately had a church group behind us, so the organisation that employs me and runs the centre is Uniting, which is the social services arm of the Uniting Church, and we're funded from the confiscated proceeds of crime. So I don't think we get as much publicly funded services as you do here. I'm really impressed at the fact that you get methadone for free, you get NSPs for free, you get drug treatment for free. That's not the case for us. So I think for us it was important to be able to say that we weren't taking the money away from other health services. But for the general population, when they heard that the church was running it and the police supported it, I think that's extremely helpful to say, well, it can't be all bad.
Cool. Okay, thank you very much, and thank you for this conversation.
Pleasure.
Cool, thank you.